And as Representative Dean moves to the table, he would like to move that House File 3534 be laid over for possible inclusion. Be laid over. We have the bill before us, and I understand there's an A1 amendment. And it's the author's amendment. Representative Dean moves the A1 amendment. Representative Dean, to your amendment.
Thank you, Mr. Chair and members. This is just a technical amendment in updating the lines 10 and 11 from hospital to emergency department and after patients in consultation with ambulance services or medical director, a technical amendment to the bill.
Are there any questions to the amendment? All those in favor of the amendment say aye.
Aye.
Those opposed say no. Motion prevails and the amendment is adopted.
Thank you, Mr. Chair and members. The bill.
As amended.
Thank you, Mr. Chair and members. The bill is, as it left the last committee, I believe, was policy. We have one-time $1 million appropriation for this bill. This is a pilot program that targets individuals who've had naloxone injection in the emergency department or had naloxone given by first responders. This allows community paramedic teams who implement this grant will provide follow-up care. With that brief introduction, I will have my testifier talk a little bit about what this would mean and how this particular program would be implemented in the field by emergency responders.
And if you could introduce yourself for the record, Mr. Testifier, Mr. Carlson.
Yep, my name is Peter Carlson, and I work for North Memorial Health. Here today representing community paramedicine and the opportunity to do more in the space of opioid overdose, and the fact that our pre-hospital responders today as paramedics are administering Narcan and then having very little opportunity to follow up after the fact. And so the community paramedic pool of providers have additional education beyond 911 or critical care training, which really encourages and allows them to be out in the community in transitions of care. So we feel that it's a data-driven opportunity to interact with a population that has very little care once they're actually released from the emergency department or the hospital, as we talked about last time I sat here. So I think, we reviewed our data in the small slice of greater Northwest Hennepin County and found 414 instances of Narcan administration over the last rolling 12 months. And of that, 70% of the lives, the incidents occurred within 3 cities, Minneapolis, Brooklyn Center, and Brooklyn Park, which to us shows a real opportunity to make an impact in a tight geographic area as well. So again, I manage staff acting as community paramedics who have access into the electronic health record used by our system along with quite a few others in the metropolitan area. And they're responding in their own personal vehicles versus an ambulance. So it's one-on-one chance to get home and do some assessment and further work. So appreciate the time and open to any questions.
Is there anyone else who would wish to testify in the audience? Representative Murphy.
Thank you, Mr. Chair, and to the testifier, I guess, Mr. Carlson. This is maybe the third iteration in the last number of years about the community paramedic and its role. This seems, now a more autonomous role without as many guardrails as we've seen in the past. And I am trying to understand the role of the community paramedic in the evaluation and assessment and plan of care for somebody post Narcan or naloxone administration, and how that is connected to the preparation, the educational preparation to do that work. As I think about it, is a fairly, when you are autonomous and in a community, it's the most difficult of the kind of practice because you are on your own and independent. So and maybe you can't, maybe this is going to require a follow-up conversation between you and I, which is fine because it is almost 10 o'clock, but I would like to understand the connection to the educational preparation for community paramedics in this
Sure.
specific role.
Mr. Carlson.
Yeah, Mr. Chair and members. Yeah, I didn't realize you guys stayed up this late. But what I would encourage or promote is a one-on-one conversation, absolutely, or some ride time and review of our curriculum. And the fact that we're never acting alone, so the autonomy that we've created in our role is in tandem to our medical director. And so we've, working under his NPI, it happens to be a male. And so I think it's well within our list of abilities to do this work in a meaningful way. We're also joined to our primary care providers within our system and other systems. So the care plan itself is being kind of fostered by primary care, but we've noticed a low level of compliance and adherence in the primary care space with the population we're looking to interact with.
Follow-up.
Thank you, Mr. Chair, and then to Mr. Carlson. Ride-along would be fun, but probably hard between now and when this omnibus bill gets put together.
Come on.
But I think it would be possible for you and I to connect, and so let's make that happen if that's okay with you.
Yeah.
Any other discussion, members?
Just to respond to Representative Murphy's question, one of the things that I think this does that's really good is it responds to, if you look at the kind of the heat map for the statewide overdoses, it's not universally spread out. It's clustered in areas that aren't necessarily where the metropolitan area is, certainly, but it's not, there's pockets where it's really heavy. And I think that that's one of the things that I like about this is it can really geographically focus on where the problems are. And as the testifier said, that the ambulance folks are seeing the same people in maybe different hospitals, but ODing in different spots, then they're actually the point of contact that's maybe consistent, which I found, I didn't know before that I learned with this. And as far as a ride-along, Representative Murphy, you're doing a lot of traveling. Maybe you could, maybe get up to one of those areas where we're focusing on in the next several weeks. But you put on a lot of miles these days.
Representative Liebling.
Thank you, Mr. Chair. And I have a few questions about this, Representative Dean. First of all, on 2.10, about the Commissioner of Health shall develop specific evaluation measures and reporting timelines for the services receiving the grants. Is the Department of Health on board with this, and do they have something in mind already? Because they don't need to come down. If the answer is yes, maybe if the answer is no, maybe they do need to come down. Okay, I'm seeing some nods up there. Okay, good, because sometimes, developing criteria after the fact and stuff like that can be difficult. The other question I have is on line 1.22, and maybe this is for the testifier. It has as part of the initial home visit, safety assessment, including whether there's a need to dispose of prescription drugs that are expired. I don't recall seeing that before. It probably was there, but that makes me wonder whether the person has to consent. I mean, what does that look like? Is the community paramedic going to go look through their medicine cabinets and under their sink and under their pillow and things like that? And what if they say, no, I don't want you to search my house? So that's kind of question number one. The second one is, if they do find something, are they also going to dispose of it? Because it says here they're going to see whether there's a need to dispose. So does that include actually saying, okay, we can take that for you and do something with it? Or does that just mean telling the person to take it to their local law enforcement office?
Mr. Carlson.
Mr. Chair and members, so two great questions, and I think the word search scares me a bit. We're definitely not searching homes. The initial visit is all about building trust, and that may take 2 or 3 visits in order to do so. But often the patients are asking us to walk through the different areas of their home and explore various medications that are in need of being disposed of. So often that's a really natural byproduct of our relationship. And then if that is identified, we're connecting that patient with a medication therapy management pharmacist or an MTM pharmacist. who's actually able to help them with the disposal. But yeah, we're educating on how or where to take those medications for disposal. We're not removing them and driving them anywhere.
Okay,
Follow
so,
up.
well,
Representative
yeah,
Blakeley.
thank you. So, thank you for that. So I don't know if that's clear in the language, but I think what you're saying is that you're just talking to the person about whether they have that need, or
Mr.
trying to
Carlson.
assess it through discussing it with the patient.
Mr.
Am I
Chair.
right?
Mr. Carlson.
Absolutely correct. So there's a lot of discussion on the subject, and oftentimes patients are quick to, that's usually one of the first areas that they want to hit is you name it, I guess. We've found anywhere from 10 bottles to 2,200 at one point with a patient in terms of leftover bottles. That was a bit of a hoarding issue. But that's often an area where patients have a high appetite for assistance in figuring out what to do with medications. Grandma passed away, brother went to jail, they're expired, the list goes on. So we're really there to advocate for the patient and help them figure out a solution for that problem.
Okay, so Mr. Chair, just to thank you.
Representative Blakeley.
Just to kind of close the loop on it, so there's no authority under this bill for the community paramedic to go searching through anybody's house or looking where the patient doesn't want them to look or isn't asking them to look, right? I just want to be really clear about
Mr.
that.
Carlson.
Mr. Chair, absolutely correct.
Thank you.
Yes.
Representative Considine.
Why, thank you, Mr. Chair. I'm looking at some of these things, develop a personalized care plan for patients. Some of the stuff would look to be Rule 25 assessments. This would seem to be the work of a social worker rather than a paramedic. I was not aware that most paramedics had this kind of training. Wouldn't this fall, like I say, under the hospital social worker to coordinate this kind of a program rather than a paramedic?
Mr. Carlson.
Mr. Chair, members, so I would say yes and no. A majority of the care plan that you referenced is really social determinant of health driven in terms of focusing how do we reach the goals for the patients. So there's 30-70 in terms of medical to social complexity that we're trying to really gain traction on with the population. I think you're absolutely right to point out that there's a fair amount of social work, if you'd like to refer to it as that, in terms of care provision. Some of that's being done at our ERs, but not enough. And so we will bring a social worker in as a part of this intervention when it's appropriate, but the community paramedic tees up and gets a lot of that working. So this is a multidisciplinary team, just to be clear, and then adding the word community to paramedic is appropriate, just given the fact that it'll be community paramedics doing this work.
Follow up. Representative Considine.
Thank you. Would you be doing Rule 25 assessments then also?
Mr. Carlson.
Mr. Chair, no, we will not be doing, so we, in conjunction with various groups, including Minnesota AIDS Project, a couple other folks in the county that we work with, again, we're bringing the resources in with that patient, and we've identified that within the population we're proposing to work with and get some additional funding, that is a gap that we've found through analysis. So it's a matter of coordinating that care.
Representative Considine. Follow up.
Thank you. Again, it looks more like to me something that would be coordinated more by a social worker rather than a paramedic. I mean, that's when I'm reading through this, it would seem to fall more under their purview than a paramedic. I'm struggling with that actually. So, thank you.
Representative Loeffler.
Well, thank you, Mr. Chair, and I think we're all wrestling with what the scope is and the appropriate responses, and I really supported the community paramedic role when it was following up with people who are discharged, particularly elderly people, and helping them understand their medications and helping them just sort of get established, maybe monitoring their blood pressure and some vital signs to see if they're adhering to the post-treatment and it's having the kind of response that they need. And I thought that was a really great program, and I think it's shown its value. For people who have overdosed on opioids, some of them may be confused seniors who took too many of their pain pills, and, maybe that's a, one-off kind of situation. But for people who are seriously addicted, have real issues, I really think we need to not have them be dependent upon someone to just do a follow-up home visit, but instead they should be referred into treatment and a Rule 25 assessment and the kind of real supports that we have for people who face really serious addictions. And I think it's really a stretch to think that a paramedic is the person who's going to help put all those pieces together. And you know, the biggest need in their life at that point is probably much more serious than just someone coming in and assessing the risks in the house. You know, and so I really feel like this needs some much more definition around it, so that, you know, if it's responding to, like I say, that accidental overdose of the confused person who might need to have ongoing medication monitoring, or maybe a home care worker who actually helps them with monitoring their medication. That's different, but if we're talking about people who potentially are seriously addicted, they need much more than a paramedic stopping by and doing a home visit. They need to have a much more serious response, and I really think this bill needs a lot more definition, rather than broadly saying anyone who's a paramedic on a program that wants to try it can start to try and intervene with some people with maybe more serious issues than a paramedic should be involved with.
Mr. Carlson, would you like to respond?
Yeah, absolutely, Mr. Chair. And so I think clarifying further on paramedic versus community paramedic is probably a logical starting point as far as the type of provider that'll be in the home doing this care, who is responding to your vulnerable geriatric population that's transitioning, but is also doing a lot of response in the younger population that you refer to as being more serious or more dependent. And so we often are a front door gateway liaison for our mental health services and our CD providers. So I do have a lot of confidence in the ability of this group to do the work that's outlined in the bill in front of you.
Well, Mr. Chair, I will just say primary care
Representative
doctors.
Loeffler.
Primary care doctors say they do that too. You know, they identify people who have mental health issues, chemical dependency issues, and et cetera. But most of them refer those people up to people who have developed real skills and expertise in responding to that. And I think that's a different sort of response. And to say that because you're the first point of contact, that you're the logical follow-up, I think for all populations isn't the kind of service system that I envision. Sure. Because I really do feel like we're just delaying the really serious intervention that a lot of people would need, who are overdosing, if we're diverting them into this kind of a program when they really need much more serious, intensive responses immediately.
Any other member questions? Final words, Chair Dean?
Thank you, Mr. Chair. Just one thing I would point out is that this community paramedic and this services that we've been looking at for the last couple of years is not meant to be a medical home or to take the place of a primary care provider or anybody else. This is an additional service that we can intersect with people, folks who are transitioning back to home, and also people who find themselves in a head-on with an overdose to follow up on that. And it seems to make some sense to me that what many of us see when we go out and we knock on doors in the community is, you know, every so often you'll knock on the door of a house and you'll say, whoa, somebody got off course here. You see boxes piled up, you see mail that hasn't been opened, you see things that aren't right, and you think somebody got off track here. And it doesn't take very long before you can figure that out. And then many people, when they see somebody who's, you know, really gotten off track, they say, wow, if somebody had just stopped by the house, they would have been able to tell us that, you know, Aunt Judy or Uncle Bill was really in a bad way. So I think that this is, I was very skeptical at first of this, and I think it's got some really good opportunities in this and other areas, so I appreciate the support.
Thank you, Chair Dean. And House File 3534, as amended, is laid over.